Welcome to this clinical walkthrough on early onset schizophrenia for UKMLA, brought to you by Medi8, your 24/7 practice partner. Today, we're going to break down a case that you're very likely to see in your exams: early onset schizophrenia. All right, we're going to tackle this in 5 clear stages. This structure is basically your roadmap for the OSCE station. It'll take you right from saying hello all the way through to the final management plan, making sure you hit every key point along the way.
So let's talk about the first 2 minutes. Honestly, these are absolutely crucial. This is where you build trust and create a safe space. If you get this part right, the rest of the consultation will go so much more smoothly.
You're going to start with a warm, professional introduction. It seems simple, but it really sets a respectful tone right from the get-go. And always, always confirm the patient's identity yourself. It's just fundamental for patient safety. Now, this is a really common trap. In this scenario, the patient's been brought in by their mom. So if you just ask, "Why are you here?" it can sound a bit confrontational. A much better way is to acknowledge the mom's concern, but then immediately pivot to the patient. It shows you're interested in their perspective. So, what do you do if your patient is being a bit evasive or just doesn't want to talk? Don't push. Instead, use this phrase. It's perfect because it reinforces that the conversation is confidential and that you're there to help, not to judge. Okay, once you've built that rapport, it's time to get to the heart of the assessment. This is where you'll sensitively explore those key features of psychosis. In your exam, you need to be ready for a few different flavors of this case. The diagnosis is the same, but the patient's specific delusions might be about being spied on, having a royal connection, or being chased by the police. You've got to be prepared for any of them. For the spying theme, you need a question that's direct, but completely non-judgmental. This is how you do it. It's an open question that lets them share their experience without feeling like you're challenging them. Now, what if the patient has a grandiose delusion? The best technique here is to use their own words. It shows that you're actually listening, and it gently invites them to tell you more. And it's the same idea for the police pursuit theme. Ask directly about their belief, and then follow up by asking for specifics. This helps you get a sense of how deeply they hold this belief. When you're asking about hallucinations, you need to be systematic. Start with hearing voices, because that's the most common. Then, dig into the details. What are the voices saying? And then, this is so important, you must ask about command hallucinations, voices telling them to do things. That's a huge risk factor. Finally, you can screen for visual hallucinations. Thought disorders can be tricky to ask about, so having these specific questions in your back pocket is a game changer. These clear, direct phrases are the best way to screen for thought insertion, withdrawal, and broadcasting. All right, so you've explored the core psychotic symptoms, but you're not done yet. Now we need to zoom out, rule out other causes, and get the bigger picture of your patient's life. Okay, listen up, because this part is absolutely non-negotiable. You have to ask about their mood, and then you have to directly ask about suicide. Let me say that again. You must always screen for suicide risk in any patient with psychosis. It's a critical safety step. To make sure you cover all your bases quickly, the FAMISH mnemonic is a lifesaver. It prompts you to ask about everything: family history, alcohol and drugs, especially cannabis, medical history, their insight into what's happening, and social factors like stress and sleep. You can practice this exact case right now. Get objective feedback on mymediate.com. Okay, this next part can feel really daunting, telling the patient what you think is going on. Your approach here has to be clear, direct, and most of all, empathetic. You want to be direct but gentle. Don't use confusing jargon. Just state the name of the condition clearly. Phrasing it like this, "It sounds like you may be going through," is a much softer way to deliver the news. As soon as you have said the word schizophrenia, your very next sentence needs to be one of hope. Explain in simple terms what it is, and immediately emphasize that it's a treatable condition and that people can get better and live full lives. We're in the home stretch now. The final, critical piece of this consultation is creating a management plan that is clear, safe, and immediate. The patient needs to know exactly what's going to happen next. Your plan needs to have 4 clear steps. 1, an urgent same-day referral to psychiatry. 2, explain what happens next, the hospital assessment. 3, briefly mention medication options. And 4, provide really solid safety netting.
And that safety netting can't be vague. You need to give concrete, actionable instructions. Tell them exactly what to do and who to call if things get worse. Give them phone numbers and leaflets, and reassure them that help will be there very, very soon. So let's just pull it all together. Why does this all point to schizophrenia in this case? Well, you've got a young adult with delusions, a clear drop in their day-to-day functioning, poor insight, and a possible risk factor of cannabis use. All those pieces fit together perfectly. And that's how you can confidently navigate this challenging station. By following this structure, you'll provide excellent, safe care for your patient. You can practice this exact case now on mymediate.com.